Well, good morning and welcome to our webinar on Should Nurses Be Free to be Change Agents and Innovation Leaders? And I'm absolutely thrilled to be hosting today alongside Wing Commander Marcus Stow and Lisa Rickers. Today's webinar is looking at the ways that we've been innovating, particularly over the last couple of years. And it's fair to say that COVID-19 pandemic has been tough on us all as nurses, well, all of us as a population as well. And we've shown real resilience in these times. But what's been absolutely fantastic, really, the silver lining, is that we've managed to innovate at such a rapid pace like we've never done before. So really it's looking at this today, it's looking at how we've shown agile leadership and how we as nurses can drive positive change in healthcare moving forwards and really share best practice and learning more broadly. I'm absolutely thrilled, as I said earlier, to introduce Wing Commander Marcus Stow, OBE. Marcus has had a really exciting 19-year career in the RAF, specialising in aeromedical evacuation, providing medical leadership and training and innovation. Really a snapshot of his career gives a bit of an insight into who he is as a person. Is back in 2011, he was deployed to Afghan, working alongside the US Marine Corps and successfully evacuated 1,100 sick and wounded patients, which is just phenomenal. He also was awarded the Order of St. John for preserving life and reducing suffering in humanity. So it's a great pleasure to welcome you today, Marcus. Equally, we're delighted to be joined by Lisa Rickers, who's a specialist bariatric nurse based up in Oxfordshire, and also the founder of iCrowd, which I'm really excited to be hearing more about today and how we can all get involved. Lisa is an expert in innovation and how to support complex needs in patients. I'm really excited to be hearing more from you both today. Just to make you all aware, we will be recording the webinar today, so just to be mindful of any comments or anything that you make, and if you have any concerns about that, please do let us know. Equally, we'll be taking questions at the end of the session, so please do, as we go through the webinar today, please pop your questions in the chat box, and I'll be fielding questions at the end once Marcus and Lisa have presented. So without further ado, it gives me great pleasure to introduce Marcus and Lisa. Thank you very much.
Good morning, everyone, and thank you all for coming. Great to see a couple of my military colleagues online. Please, they'll know I'm just talking rubbish, so please don't put anything in the chat that disabuses what I'm saying. I'm going to share my screen. Let's hope this works. Amazing. Okay, welcome to the webinar. Why are we here? So there's a really obvious question at the front end. Should nurses be free? Oh God, there's two shoulds in there. That's my bad. Lisa, you can tell me off later. Be free to be change agents and innovation leaders. Well, I think we know the answer, and the answer is yes. But what we're going to talk through is why we haven't been in the main in the past, and what we can do to help in the future. And we've shaped this particular session aimed at this group who are senior nurse leaders, and it's about facilitation, enablement. But also, if you want to do any innovation yourselves, feel free to take on board these lessons or come back to us later, and we can help you or any of your personnel colleagues that need assistance in the future. Why am I sitting here? I've had a varied career. I've tried to innovate my whole career, not knowing it was innovation. As Joe or Sarah, who are on the call, will know, innovation can just be a cable tie hanging up a bag of fluid in a helicopter because you don't have a drip stand. It can be taping 4 tongue depressors together with zinc tape and using them to write a patient's observations on instead of their forehead with a marker pen. Equally, it can be telemedicine with a camera over a surgical patient being advised by a neurosurgeon 4,000 miles away. Innovation has that entire breadth. In this particular session, feel free in the questions. We're not really going to go into the definitions of innovation and the differences between innovation and quality improvement and research, but we can discuss that later. And we haven't quite got time to dig into that today. The premise being innovation is any fairly rapid change that you can make to improve care, make things more efficient, and make things better. Let's go with that as a working definition. Lisa, please nod, but that's, yeah, good, great. Right, moving on for my spelling mistake. Okay, here we are. We're in the wasteland of stagnation. Okay, now I think we've all been here. We've all been in places where nothing changes. We want to change things, especially when we were young and thrusting nurses who could see problems all over our clinical areas or our managerial areas, doesn't matter. And the first thing we do, we come up with a bright idea. There's a little cave with a light bulb in it down there. What happens next? Well, you've got this great idea. Please excuse the cartoon, but I love it. And you pick up the idea, and you've got the pill of we're too busy to change. Because as we know, and this is getting worse, we don't have enough nurses in the UK, and in fact, clinical staff in general. And it's very, very hard to enact anything that looks like a change, especially a radical change, at pace when everyone's just running around trying to sort today out. Get through the day, get through the next shift, see the next 11 patients, whatever your task is. And often, as an individual, I've been the person who wanted to make the change, and I got put back in my box, as we say in the military, because everyone's just too busy. Or I've been the manager who's like, yeah. No, we'll get to that. Great. Anyway, so we're too busy to change. Not a great excuse, and we'll talk about that later, but a very understandable one, okay, because there are a lot of pressures on us. What's the next thing? Well, we've got there's the bright idea. Then we got sort of the zombie of we tried this before. So you go into your wards. Let's imagine I'm a band grade. What am I, band 6, grade D grade, whatever that is these days. I'm showing my age. I'm a band 6 nurse, so I walk up to my sister and say, I think the resus trolley would be better placed nearer the patients. Obvious. We tried that 5 years ago, didn't work, given up on it. And actually, most of the time it wasn't tried in the way that you are expressing, or the time is now right, or there is now technology that will help you overcome that. Actually, an innovation might not be moving the resus trolley, but putting a defib in every bay, or having a smaller defib that's more portable and you carry around. There's a whole gamut of things that you can throw in there. And that's part of our responsibility as managers, is when someone brings you a problem and a solution, you actually might help them refine that solution down to, actually, do we need a resus trolley? Question one. So you've got the we tried it before reasoning, which usually doesn't hold up too much weight. But then you've got, the pink head zombie of credibility, and the axe-headed zombie of finance and control and business and change management within a hospital, all the management structures that are there. And this picture just represents all the hurdles you would have to get through, right the way up to maybe even the afro-haired zombie of the chief exec, or the chief nurse. That could be anyone or anything. And the credibility thing is a shame, because it does appear, and Lisa will give you some examples later, that those who are able to innovate at the moment in nursing are tending to be those near the pinnacle of their career, who are specialist nurses, matrons, chief nurses. They've got a weight of experience, they've got backing of other people. It's not tending to be our subordinates, the people at the coalface. And the people at the coalface, and this goes back to the original question, are those who understand the problem best, because they are facing that problem day in, day out. And they're often people who are most passionate about the problem. Why? Well, obviously, because they care about what they're doing, they care about their patients. The great thing about that passion is it can be harnessed. It can be harnessed in a really strong and useful way by managers and leaders to push, their solution. The solution of this junior may not be right, but the problem still exists. So shape that passion, help them with that passion, and push them through all of these hurdles that they face, whether they be spiked pits, pills, pink head zombies, doesn't matter. I've left this slide in because it gets really complex when you start including other agencies like the MHRA. If you start bringing devices in, or it's a new device, something like that, that is a problem. And I'll talk about my eating the frog concept later on in this chat. Okay, so that's enough of the cartoons and the gloom. And here we are in the garden of innovation and inspiration. How do we get here? How do we get from all of those challenges and blockers to a place where nurses, any nurse or midwife, and actually any AHP can come forth with a very simple solution to a problem and be supported in doing so? Okay. Generally, the one word is collaboration, and that is seeking help or being helped. And it's better if that help is obvious and around you. And if your help is your direct line manager, well, that's how it should be. But there are a whole range of different organizations that Lisa and I work with and have worked with in the past. We're front and center there, the I crowd, just to push that. J-Hub Med in the bottom right is my old organization that I'm still advising for. Had a great chat about drones yesterday with them. I've worked with NHSX and most of these I've worked with, in fact. And Lisa is on the clinical entrepreneur program at the bottom, and I am a mentor on that program. And we're tied into Tony Young in that as well. So there's all these outside organizations who can help. Equally, it doesn't have to be the junior who seeks this help. You can signpost them, and we'll get to that. So it is possible. You can make change. You can make very small change locally. You can then make that a regional or unit-wide change. You can move that throughout an entire trust. You can move that across the entire NHS, and you can go abroad, overseas, if it's that good an idea. And there are people who will help you do that. It is a challenge, don't get me wrong. Just to prove that it is possible, here's just some pictures of stuff that I did in the last 4 years with the team. These are mostly telemedicine things. We did lots of other stuff as well, but we have here a surgical telemedicine platform called Proximy in the top right and the left, putting surgical cameras over the top of patients and providing advice. We've got a WhatsApp for doctors called Pando that we're now using all over the world to provide advice. We've got an ultrasound unit that will plug into a phone that we can use in Mali and send ultrasound pictures via the SAT cube that's in the bottom right there. We can provide advice using all of these techniques. And telemedicine in the British forces would not have existed without J-Hub Med and the hard work of many nurses and doctors and various other allied healthcare professionals. So they're my examples. Lisa is about to give you some of hers, if that's all right, and I'll mute myself as briefed.
Thank you, Marcus. Thanks for that. So yes, nice to be here and have the opportunity to talk about innovation in nursing. I'm going to start with the first example, Dr. Roxanne Crosby, and she started her career based as a diabetes nurse on a urology ward, and has obviously then progressed into doing a PhD, and she's using digital to increase the uptake of diabetic eye screening at Moorfields Eye Hospital in the UK. So diabetic retinopathy accounts for around 4%, and there's an estimate of 1.93 million people living with sight loss, and as we kind of live longer as well, we need to find new ways in which to manage those demands. So she was finding a feasible way to increase screening uptake, and that was really important. And what's really nice about this initiative as well is that it actually upskills the levels of community nurses who now have access to a cloud-based smart clinical history web app, which enables specialist clinical history to be obtained, and then that technology can ensure that information is transferred in order that it gets special reporting. So being able to do this in people's own homes as well, so not having to have problems with access, has really opened up access for people to take up screening who perhaps were not taking this option in the first place. And it's also enabled people to monitor at home with their ongoing treatments and to ensure that they're getting appropriate follow-up. So I think this is a really great example of how we can see a problem and look into solutions and using tech in order to enable those solutions as well. So coming on to another example, and this is an example from a nurse in the USA, and they've set up a platform called IntelliCare, which is using digital to create a workforce management platform. So the problem that they was trying to address was they were finding that there was short staffing issues, and that nurses there were being mandatory kind of forced to do overtime, which meant that this impacted on their quality of life and time spent with their family. And so the solution was that they designed a work management platform that assisted in filling out last minute calls. So nurses could put down their availability, and obviously then shifts could be filled by a number of different nurses. And they've actually realised that although this started as a small initiative, that actually this problem was not unique to their hospital. And this is something that's now being scaled and happening across the USA. And you know, they've taken this platform and they're now employing a number of different nursing staff in order to support nurses. So it's enabling nurses to have that flexibility in their work-life balance. And it's also making sure that shifts are covered and that, staff wards are safe as well. And actually, he's the only nurse that I know that secured 45 million capital investment. So, you know, it's certainly leading the way in terms of what is possible with nurses leading innovation. Bradley Cheetham, he is a nurse that's in Australia. So I've tried to use examples from international examples. And he was a nurse that's worked in ICU, and he's also got a military career as well. So linked in with Marcus as well, but he's using digital to train healthcare professionals. And so he was thinking about ways in which he could enable frontline nurses in busy hospitals to have up-to-date skills and qualifications that made sure that we improved a patient experience. And so they're using VR in order to help to deliver this at scale. I know he's in talks with a number of different countries now, and he's also has worked in hospitals in London as well. So I'm sure we're going to be seeing more of Bradley in the not too distant future. And he's building a range of tailored education packages, which you can access on your phone, your tablet, your PC, or even with a VR headset. And I think we're seeing that a lot more in nurse education as well. And it certainly is probably something that's going to help us overcome the barriers to getting experience out on wards as we increase the number of nursing students as well, and to ensure that they get that immersive experience. And it's a way as well that we can ensure that people can get feedback in terms of their training, and also that can be fed back to institutions as well in order to review performance. And then finally, coming back to Bernadette Porter, who is one of our nurses on the Clinical Entrepreneur Programme as well. She's been on the programme for a few years now, and she's developed Neuroresponse. She's using a digital care model that enables people living with neurological conditions to have more autonomy in their care. And there's currently 10 million people who are living with neurological conditions in the UK. And outside of planned care, there's a lack of that expert advice when there's acute need. And this often leaves patients the only option to attend A&E. And obviously this can be frustrating. It leads to increased waiting times and can lead to being admitted onto a general ward. And Bernadette's got a vision in terms of how that could be different. And so Neuroresponse is always available. It provides 24-hour expert support, and it also can ensure that test kits can be sent out and couriered to patients' door. And then if medication is required, these can be couriered to them directly, really just avoiding any unnecessary admissions. And this access is great because it's 24 hours. And it also means that patients can reduce their time for assessment of any new MS symptoms. And it ensures that the treatment of urinary tract infections can be dealt with much easier and faster. And finally, they're looking at ways in which they can ensure that information can be shared with the people that's involved in that care. And Bernadette set this up as it's a non-profit organisation. And I think we see that a lot more in nursing in terms when we're not necessarily driven towards the Silicon Valley type approach in terms of healthcare innovation.
Thanks, Lisa. As always, you provide all the evidence. I just provide all the waffle. But we're a great team. So how do you create a culture of innovation? Again, I normally give the briefing that we're giving now to talk about how innovation is. Actually, what we're trying to support with you guys is how you can support innovation within your own areas and help others. And we're happy to help after this webinar. You'll have to excuse the noise for a little bit. Okay, this is the key part. Support those who are passionate about solving a problem. We've all been the passionate person, and we've all, I have to say, we probably all have poo-pooed a passionate person at some point, usually due to stress, tiredness, lack of time, lack of energy. You didn't take the time to actually listen, so you just poo-pooed it as, no, we did this last week, it didn't work. So always support someone who's passionate. Key, provide a psychologically safe and open space to share ideas. Okay, this could be if you're working in a hospital trust, this could be just allocating innovation time within your nurse management meeting or your ward meeting or whatever. Or it could be you just have a separate coffee, let's discuss problems session once a month. Doesn't matter. You know, equally, I quite like the idea of a ward, because I came from wards back in the day. Every monthly meeting, someone goes, right, you all put in an innovation, an idea, just an idea, anything that we can change on the ward. We will try one this month, if obviously if it's safe, and that's something I make very clear. Don't make change if it isn't safe. But we will try it, and if it fails, that doesn't matter. And that's the other thing about innovation. It is about experimentation. It's not just about making permanent change. And this is one of the issues the NHS has with innovation, as does the MOD, is failure is especially when money is involved, with public monies, can be a real issue. And I can talk that through with any of you afterwards, or you can ask questions about that, because I've faced that challenge. Okay, despite the pressures, innovation almost always, whether it's QI or innovation, creates efficiencies and improves patient care. Yes, it will take a bit of effort in the short or medium term, but even if you're too busy pushing the wheelbarrow on the square wheels, when someone appears with the round wheel, and you tell them, no, we haven't got time to change the wheel. I mean, it's just obvious. We all know this, but it's hard to remember when you're in the pressured moment. Over to you, Lisa.
So also help others to develop their idea and their value propositions and clearly define their unique selling points as well. As nurses, this is not something that we are taught when we do our qualifications. And so it's often things that we have to learn. And I know that that's what I had to do in terms of looking at all of these things related to innovation. So I think having something that would be available for people so that we can take them through that process to really help support them just to clearly define that idea in order to take it to the next level, or to take it to their sister or their matron on the wards or wherever, really. I think that there's a lot that we can do to support people with that. I think Marcus might froze again. Can we have the next point? Okay. The other thing about it is that we've all kind of been through this phase of Silicon Valley and health tech innovation has explosion. And what we see is that there's this thing about it needing to make money. And I think we sometimes forget that this is about improving patient care, improving efficiencies. And actually, if we don't make money, but all of those things are ticked, is this not good innovation? So we can see in terms of not-for-profit social enterprises, and also thinking about innovation that happens on an entrepreneurial level, so within departments and hospitals as opposed to entrepreneurial outside. help and signpost others to seek help. So we've talked about the slide in terms of where people can go and get some extra help, advice, and really important to collaborate. What we often see is some great ideas in terms of what people are doing, but they can be often siloed and not really discussed or shared. And that's such a shame, because that's something that could be expanded into other areas as well, and benefiting patient care. Getting multidisciplinary opinion is really important when you're starting out with your idea. And I think we've put on here in terms of allied health professionals, doctors, porters and managers. And one of the points I wanted to say was really is that I've spoken to a number of different health tech startups, and often ask them, do they have any nurses within their team? And I'm always told that no, that they don't necessarily have any nurses, and they don't see a need to have nurses as part of their core team. But when we sort of ask them in terms of, well, who tells your patients about these products, or who onboards these patients? And it is the nurses that are often the ones that's leading this. So to me, it just seems a really missed opportunity for developers to really sort of take advantage of that and actually make sure that we're engaged right from the beginning, because we could probably help a lot in terms of some of the mistakes that's made, and sort of sign people towards better options or what might work. We're often, the nurses are the closest to the problems, and so we're often the ones that see it, understand it and experience it.
This is just a get started in innovation piece of advice, which is when you come up with a decent solution for your innovation problem, the hardest thing needs to be tackled first. You need to work out what the hardest thing is. If that's finance, tackle that first. If it's MHRA clearance, tackle that. GDPR, whatever. What you don't want to do is get a year and a half down the line and then find that you've got one of these unbreakable blockers in your way and you've wasted a year and a half. How do you find out what that blocker is? You go to those organizations that we've just talked about. You can come to me and Lisa, because we've faced almost all of them. If nothing else, my chain of command is one of the greatest challenges, in a great way. But you know, I can help anyone in the military, for example, sell an idea to stakeholders, but there's lots of other things that we can help with. So always eat the frog first. Identifying the frog is key. And then really, this is the key thing, especially for nurses, and I give this brief to everyone I speak to about innovation. Having had to pitch for millions of pounds worth of support for different projects, it is way easier to pitch and sell if you are talking about a patient, even if that's second or third order effect. Just remember, it's not about the tech, it's not about the shiny thing, it's not even necessarily about the staff member, because if you free up some of their time, that is more time that they have for a patient. So always put the patient at the heart of the innovation. That will also help you maintain the passion that's at the top of this slide. Yeah, and you will always return to that. And innovation is a rocky road. You'll hit doors, barriers, challenges, you'll be told no, you'll be turned away, you won't get the funding, you won't get the sponsorship, and you will have to have something to fall back on. And usually as nurses, it is the patient. And that will drive you forward still. If it's about tech, and it will change, the tech will change. You know, so don't become too invested in your solution, but get invested in the problem and the patient. Have you got anything on that one, Lisa?
I'll just reiterate your last point there. You know, this is getting passionate about the problem, and sometimes the solution isn't the right solution and it needs to change. And if you invest too much in a solution, you don't want to give it up, because you know how hard you've worked to get to that point. So it's really, I think that's a really key point for everyone.
Yeah, just stay positive, optimistic and passionate. My favorite quote of all time is boundless optimism is a force multiplier. And anyone who's worked with me in the military will understand that is Marcus's modus operandi. I genuinely just tell everyone it will be okay. We'll get it done. It will be okay. We'll get it done. I go into an office on my own with my 2IC and cry, right? But I come back out and I go, it'll get done. We're going to get it done. And this has got me through 9 overseas tours. It's got me through numerous exercises. If Joe's on the call, she's shaking her head at this moment because she's been part of this annoying, boundless optimism. But it does work. And it really does work. Just keep telling people it's going to work. And that's it, really. I think that's our last point. Let's have a look. Boom, we're in. Questions, please.
Well, thank you both. Wow, what an incredible presentation. I guess the key points for me, they're passionate about the problem and putting the patient at the heart of innovation sounds so straightforward, but actually so key and important. And the boundless optimism, I love, absolutely love that. Thank you, Marcus. I think Joe will be really pleased I'll be taking that on board too.
It was Colin Powell, actually, the quote's from Colin Powell.
Thank you. Oh, great. So have we got any questions at all? If you feel free to pop them into the chat box. If you've got any questions for Marcus and Lisa, we've got quite a unique opportunity to ask them about their projects, innovation. I'm particularly interested about the clinical entrepreneur program. So I had the pleasure of meeting Tony Young a couple of years ago. How were you involved in the project and what projects have you supported? It's absolutely fascinating program that's being run.
Yeah, so I've kind of chipped in with quite a few of them. In fact, my favourite is probably a ventilator that I was helping sort of push into the military. It was a small portable ventilator, cheap disposable ventilator as well, which we were looking at about 3 years ago with an entrepreneur out of Imperial. And his brother's an engineer, he's a doctor. And they were working on that, of course, and we were trying to shape that for forward evac, forward medevac, because you don't want these big clunky £20,000 things that last 10 minutes on battery. So we were looking at a cheaper version, actual disposable, also good in the radiological chemical environment, because you don't want to reuse a ventilator. Anyway, then COVID hit. And in fact, what happened at the beginning of COVID, I think it was about 90% of our projects in the military had a utility because they were about looking after patients at reach. They were looking about distal care, distal support, and respiratory disorders as well. The ultrasound project came in as well. And so we pivoted into the corona response. And in fact, Tony and I presented to the Cabinet Office this solution, and it was part of the ventilator challenge. I don't know if you remember back in March last year. So ours was one of the ventilators in that. I mean, they all, in the end, they all got not cold is the wrong word, because all of the ventilators advanced 10 years in about 4 months, which is great, and they're all now going on to do other stuff. But they didn't get used for corona because it didn't get as bad as we thought it was going to with the ventilators. So that was a great one. And Tony and I often, there's a drone project he and I are now working on out of Cornwall with a company called Drone Prep. And that we're sort of operating across that. And then I've mentored a few of the members who are currently on the program at the moment. So yeah, it's been fun. Lisa, you've got more experience of it because you're in it.
Wow, yeah, I'd love to. It's fascinating.
Yeah, no, I joined the clinical entrepreneur program in February this year. So it's a great platform to learn and get the skills, make contacts, network. I'm working on a project at the moment that's looking to transform surgical preparation, and I've been working with bariatric patients and preparing them for surgery for the last 8 years. So I'm looking to put this into a digital project that we can then sort of use as an app to support other people. And actually, lots of people as well don't have the opportunity to have surgery because they're told to lose weight or they're sort of excluded from surgery. So this means that we'll have something in order to be able to offer people to help them to access those services. So It's really exciting. I'm learning lots, and there's still so much more that I've got to learn, and so much that I don't still know. So it's a kind of learning in action. So, but I'm really happy to sort of share my knowledge that I've learned so far and help other people. But the other thing we should say, Marcus, as well, is that the Clinical Entrepreneur Programme is just out again this year. So it's now accepting for people to apply for the programme. So, yeah, but, you know, if you want to talk and ask anything about that, then please do.
Yeah, I'm on the screening panel, actually. So my LinkedIn is somewhere. Yeah, it will get sent out. But yeah, I helped the last 2 years on the screening, which is fascinating. There's never enough nurses on it.
Well, there you go. Let's hope today's inspired a few people.
And I think I am the only nurse on the screening panel, which is also a shame. So yeah, if anyone sees Tony Young soon.
Oh, we just muted Marcus. We lost you, unfortunately.
Yeah, if anyone sees Tony, can you hear me?
Yeah, we can hear you. Yeah.
Tony Young, just let him know he needs more nurses.
Absolutely. Well, thank you. Well, fascinating. I've heard a bit about the programme, but only a couple of years ago, so great to get an update on how well everyone's doing. Any questions? I can't see. Oh, here we are. How many midwives have been successful? Anyone aware of how many midwives have been successful? It's a good question. Jan.
There are a couple of midwives on the programme, so they have been successful, and you know they're looking. And I think that it's a great area that's in need of a lot of innovation that needs to be led by frontline. So there's clearly a lot of opportunity, and there's obviously a need in order to improve services, and that's always a good kind of motivation into thinking about new ways to deliver care. So yeah, I mean, I would welcome more nursing and midwifery kind of innovations. And that's why in terms we've set up the iCrowd as well to support people and just to try and democratize healthcare innovation a little bit more, because actually at the minute it's not really been open or as open to nurses and midwives and other allied health professionals. So there's a lot of work that we need to do.
I'm currently mentoring one of the midwives on the program, actually. And she's got a great idea. I'm under non-disclosure agreement, so I can't talk to you about it. But actually, it's an interesting point. Here's another blocker: is intellectual property, and that is something that's often the frog, and so it's one worth getting advice on early, because people are either frightened by it or they get it wrong, and and so get advice early. I've got some good contacts who can help with IP. This particular midwife has been hamstrung by her own trust, who will remain nameless. And they've applied so much IP to her product that she came up with on their time that she can't share the idea with anyone, which means she can't pitch it to anyone, which means she can't get sponsorship or agreement off anyone. And they've gone completely over the top, because this particular trust is very used to securing money out of their own personnel. And I guess I would say, if you are coming up with something that you think might make money in the future, have a think about how you share that within your own trust, but don't stop it from sharing with others. So there's this belief that if you tell someone else, they're going to steal your idea and run away with it. I mean, that's highly unlikely. I've never known it happen. Being a big industry isn't that interested in small innovations either. So just talk to others about it, especially those you trust. Collaboration is key. You can't do this on your own. You're not an island.
Very true. Thanks, Marcus. And really good point. Collaboration is key, isn't it? Lisa, it'd be really nice to hear a bit more about iCrowd, if you're able to share a bit more. How could we get involved?
Yes, certainly. I mean, I guess I started the iCrowd. That was right at the very beginning of going into lockdown, and I had the experience of going across to because we were all digital. I was able to go and partake in a health hackathon in the States, and so there was over about 900 people all together trying to solve different ideas. And we were looking at sort of ways in which we could kind of deliver digital products and things to rural areas. Obviously, that's a much probably bigger problem in America than it is in the UK. And so we came up with an idea of using some of the technology in mobile phones, a bit like they do in terms of, press 1 for, to hear your bank balance, and press 2 for making a withdrawal. And so we came up with an idea in terms of that. And then during the weekend, we had to pitch that back. And we actually won our kind of category as well. So that was always good. But it meant really collaborating, because we had nurses from Africa, myself from the UK, and also nurses and physios from America as well. That was all involved in that idea. So it really did enable collaboration. And then we also had people who could help us in terms of some of the tech side of things as well.
God, that's fantastic.
So I came back really, really motivated from that, and just thought, God, why is there nothing like this in the UK? We're really missing this, and it would be great. And so we just set up a group, and we're building that. I'm really wanting to sort of think about health care innovation, but to get other people included in the conversation that perhaps hasn't been included so far, and looking to see where we can sort of really look at how we can solve ideas, but in a slightly new way. So for an example would be sort of thinking about how we might be able to work with fitness instructors in order to kind of upskill them in certain skills and to help keep people healthy and well. So just getting different conversations, and also getting different people to the table, because I know I've struggled to get any seat at the table to talk about innovation, and trust me, I've banged on lots of doors. I'm very persistent.
Lisa, thank you. Oh, we've got a couple of questions coming through from the team, so please feel free, if you don't feel confident to say it, please pop it in the chat box. So do you need evidence to be able to push an innovation?
I'll get this one.
Okay, great, Marcus, over to you.
Right, so this is one of the key differences, I think, between innovation and research specifically, and often QI. Sometimes the solution to a problem comes before you realised it was a problem, and therefore it's almost impossible to provide what looks like formal academic evidence. However, it is possible to prove something will work by trialing it, and that's where innovation is a bit different, in that you trial what you want to do, as long as it's safe, and then if that works, just introduce it if you can. And evidence you may pull evidence as you trial it. So one of our projects, using a rehabilitation app, we ran a randomized controlled trial at the same time, but we still introduced the app because it wasn't going to do any harm. And it was already a thing that was happening around the world anyway. We were just introducing a modern technology into a slightly antiquated system. The most interesting one in my world, how long have I got? I need to keep this to a short story. We've got 15 minutes, so you've got time. So I think we're all hanging on your word, so please do that. So here's a very, very military specific concept, although it does work for transfer care as well. Is we got approached by a company 4 years ago who had taken oxygen generation using mixing of powders, basically chemical oxygen generation, which historically has been massive stuff, into a cylinder that was basically the size of a D-size cylinder, plastic, and so half the weight, produced about half the oxygen, but if you shot it, it just exploded into harmless powder. Whereas if you shoot a D-size cylinder, it's the same as a 10-kilogram IED, which is why we have never taken oxygen onto the battlefield. Now, Jo Matheson, if she's here, has carried oxygen in helicopters forward, and may have carried oxygen from a helicopter, but our medics don't. Okay. Sorry, I've just seen a chat message.
That's okay.
And this powdered oxygen solution was absolutely groundbreaking, obvious, and safe. It'd been tested, British Standards Institute, all that stuff. And so we wanted to almost immediately introduce it into British military. What was funny is the first answer was, we've never needed this before. And you're like, and all of us, I'm sure, can agree that oxygen and trauma, they work pretty well. But of course, there's been no research study on oxygen on battlefield trauma because we've never been able to put oxygen in the battlefield. So we now have a solution that solves a problem that we had forgotten is a problem. So we've been doing best effort, bag valve mask, and that's about it. So we had to resell the problem that's been in existence for as long as military medicine has. But of course, everyone's like, well, why do we need this? We never needed it before. No, you only now need it because the technology allows it to be possible. Hold on, I need to turn that all off. And then, very interestingly, the chief anaesthetist for the British military got asked in the pitch, will it save lives? Because he was pitching to a general who was not a medic. And this full colonel said, well, it should do, sir. And the general went, what do you mean it should do? Said, well, oxygen does save lives in trauma, but I can't tell you because there's been no research done on it. There's been no randomized controlled trial. And the general's like, well, will it save lives or not? I'm about to invest £1 million or £500,000 in this. I said, well, it's very likely to, sir. And it's the same thing that we have in medicine. We're all taught to never give absolutes unless there's a massive research base. But look at, this is obvious. This is beyond or obvious. And eventually, the chief anaesthetist himself, I'm sure Tom Woolley wouldn't mind me saying this, took himself away and said, if I cannot say something is going to save lives because it's evidentially, not direct evidentially, but evidentially true, then who can? And that was a mind switch for him. And what we did is we trialed it. We trialed it, and it was proven to be safe. And we haven't quite rolled that one out yet, but yeah, it was a fascinating case where you have to invent the problem after the fact. So no, you don't need evidence. Evidence can come at the same time. It can come afterwards. If you can prove efficacy, efficiency, in the short term, then why not trial it? And this could be a process. It can be a piece of kit. It can be a technology. It can be some training. There's a whole load of things you can do. There you go. That was a long answer to a short question.
No, it was a good example as well. And have you ended up publishing your findings on that?
So that one, of course, we haven't been in a full-scale war since we've introduced it. So, and that's the thing. At the pitch, I had to say, sir, I can't prove this without, academically, because we can't wish for an all-out war. But wouldn't you rather have it before we go than during or after? So the other military people on this call will agree with me. We innovated when we went into Iraq. Am I breaking up?
Yeah, signal was a little slow then, but I think we got it. Said you innovate actually on the ground. I think that's what I heard from you there.
Yeah, we innovated on the ground, and that's why J-Hub Med was created, to innovate between conflicts so that we keep the glide path of innovation going without having to go to war again in order to learn that we need helicopters with blood on, that we need oxygen at the battlefield, we need data passage back through the chain, the medevac chain. So yeah, it's about maintaining innovation outside of a crisis. So whilst Corona has been amazing for innovation, we mustn't slow down once that crisis.
We've muted Marcus, unfortunately, but great, thank you. Really good point, and really, really interesting, insightful story too. I think there's just a secondary question to that about how can you present that innovation to the trust executive or the board, which is a really good question, actually. Again, I think it's pointing to Lisa to answer that.
It is a really good question, and it's a difficult one as well. It's not an easy one. But there are things out there now that's trying to make things easier. So, I mean, having, the support and help to sort of fine tune your idea and make sure you get all the stakeholders involved to sort of give their support. And, sometimes that might shape the idea in a different way. There is some really good initiatives out there. So things like innovators and accelerators can sometimes help in terms of getting access to the right people within trusts. Some trusts will have their own innovation hubs that you can approach, and digital transformation leads that you can share your ideas with, and that might elevate you to get to the right people in order to take that forward. But there's a great initiative that's happening in Leeds, and this is like where we can start to get frontline staff involved in innovation, and they're actually putting out scouts to go onto the front line to find out those innovation ideas and to take them forward, to help support them, to nurture, to grow them, and to sort of ensure that they get to the right level and the right support in order to take that forward. So I think that's a really exciting change. And it'd be really great to see what happens in Leeds as well with regards to that.
Yeah.
But I think we could do with some more innovations like that in terms of ensuring that, you know, all our voices get heard as well.
Great. I think Marcus has just added to that. Well, I'll speak on your behalf, Marcus, in case of your internet connection. So hospital at Leeds, University College, Chelsea, Westminster, John Radcliffe and Oxford, Guy's and Tommy's all have innovation hubs. So there's a link for all of us to connect with, and perhaps go back to your own trusts as well and say, look, they're doing this in these hospitals. Why don't we try it here? Be bold. Be bold.
Yeah.
Imperial does as well, but it's an interesting one at Imperial.
Great. Okay. Thank you. Thanks very much. Any other questions for Marcus and Lisa? That's been a fascinating last hour. Thank you. No questions. Well, we've got contact details. If any of you wanted to get in contact with Marcus and Lisa, they've kindly put their details in the chat box. If you wanted to email them separately, and equally, if you wanted further information from us at the Florence Nightingale Foundation, please do drop us a line as well. I hope you found this morning really helpful. I know I have. It's been got so much food for thought and thinking how we can integrate innovation into our programs, actually. So Lisa and Marcus, I'll be in touch too. But thank you all. Thank you for joining us this morning. And we look forward to seeing you at some of our future webinars. We've got about 2 a month running now. So please keep your eyes out, and we'll keep sending you the details. Thank you, everybody. Have a wonderful day.
It's been an absolute pleasure. Thank you for hosting, Lucy. It's been brilliant. Again, stay passionate. Put the patient at the heart of your innovation. Don't give up, and boundless optimism is a force multiplier. There you go. That's my last words.
Thank you so much.
I just wanted to say thank you for an opportunity to talk about innovation. It's something I'm really passionate about, and if anybody wants to kind of work with us at the iCrowd as well, then please do get in touch. We're really excited to see the next generation of nurses and to think how we can change patient care. My goal and my aim is to get 10% of nurses in innovation. So,
wow, let's see if we can help you with that, Lisa. Definitely. Let's see if we can help you. This is hopefully just the start.